Good morning and a warm welcome to all of you today. To today's webinar on chronic kidney disease, learn, act, thrive. The day is sorry. The day is important as it commemorates the World Kidney Day, observed every year on March 13th. Presented by the Kauvery Hospital in collaboration with the Hindu under its wellness series, today's discussion, I am sure, will leave us all a little more knowledgeable about kidney disease, which is a silent killer due to lack of physical symptoms. This quite often leads to the damage of the vital organs, but the vital organ. Early diagnosis helps to manage and slow down the disease, even though it is a progressive and an irreversible disease. Medicines, dialysis, and transplant is the threefold treatment option that enables patients to live a longer and a better quality life. On our panel today, we have three senior experts, all from different branches of the Kauvery Hospital. And I would first now like to invite Dr. K. Abhirami to set the ball rolling. A renowned nephrologist practicing in Salem, Dr. Abhirami is the consultant nephrologist and urologist science. She obtained her DM in nephrology from All India Institute of Medical Sciences, Delhi, and is a member of the Royal College of Physicians, UK. She has also completed fellowship in nephrology from University of Toronto, Canada. With more than 2 decades of experience behind her, Dr. Abhirami's professional interests extend to critical care nephrology, epidemiology, preventive nephrology, and electrolyte disorders. She specializes in advanced procedures such as hemoperfusion and plasmapheresis. Dr. Abhirami will give a presentation on chronic kidney disease, its awareness and education. So, welcome, Dr. Abhirami.
Thank you, Ms. Soma. Thank you for that kind introduction. Good morning, everyone. Just let me start my presentation. Okay. Can you see my slides?
Yes, ma'am.
Yeah. So today we're going to talk about creating awareness on chronic kidney disease, which we call as CKD. Okay. As Ms. Soma Basu was telling, this is to commemorate the World Kidney Day, which is celebrated or uh,
So,
So it's not a celebration, it is to create awareness. It is done second Thursday of every March. It's going to be tomorrow. And every year there is a theme for it. And this year's theme is to advance equitable access of care and to optimize the medication practice in nephrology. This was started in 2004 and it's been endorsed by almost all the major nephrology associations, including the Indian Society of Nephrology. So let's first learn a little bit about our kidneys. There are two kidneys. We all know that it's a bean-shaped structure. It's located in our back under the rib cage, and so it's well protected from trauma. And the kidney makes urine. The urine comes down in a pipe called ureter, then gets stored in a bag-like structure called bladder, and then it's expelled out through urethra. So if you look at the microscopic structure of the kidney, what I mean is something like a brick in a building. It consists of mainly nephron. Nephron has got a filtration portion called glomerulus, and then it has a long segment of tube, which will fine tune the filtrate so that we get a urine the way we see it, and it needs blood supply. And what does the kidney do? We all know kidney is a filter. It filters whatever is not needed and then excretes through the urine. But we do not know that it is also an endocrine organ and it produces renin-angiotensin, which helps in controlling the blood pressure. It helps in producing erythropoietin. The erythropoietin only makes the bone marrow produce red blood cells, or if there are red blood cells are less, then we call it anemia. The vitamin D hormone is activated in the kidney. Vitamin D is required for bone health. Apart from that, it keeps water in balance and it also keeps innumerable minerals and salts under control in balance in the body, like sodium, potassium, calcium, chloride, bicarbonate. All the minerals and salts are kept in balance with the help of the kidneys. So, what are the diseases of the kidney? One is to look at it structurally. So, you can have diseases which affects the glomerulus, the filter, or the tubes, or the blood vessels. But another way of looking at kidney diseases based on the time frame. So, if something happens within days to weeks, then we call it acute kidney injury. And if something happens over a period of months, we call it chronic kidney disease. Today's awareness is mainly about chronic kidney disease because it's a silent disease, and the epidemiology is such that huge population is affected by chronic kidney disease. So, what is chronic kidney disease? Anything which affects the function of the kidney and lasts more than 3 months. Then we call it chronic kidney disease. Well, things to remember is chronic kidney disease is usually irreversible. Not all chronic kidney disease is kidney failure, but chronic kidney disease usually progresses inexorably towards kidney failure. But the time duration will depend on the disease and how we take care of the kidneys at this stage. And usually the kidneys will be smaller in chronic kidney disease. As I said before, the epidemiology is huge. About 17% of our Indian population has chronic kidney disease at various stages. Luckily, most of them would be having early stages rather than advanced stages. And what is the cause for this chronic kidney disease in India? High blood sugars or diabetes and high blood pressure or hypertension are the two major causes of chronic kidney disease. The third important part, if you see, there will be a huge chunk caused by unknown diseases, or we do not know when we diagnose. This number is high in Indian population. To some extent, it's attributed to the way we take medicines. A lot of medicines are available over the counter, and people do end up taking medicines without prescription or with prescription for a longer period of time than it was intended to be. And once you have chronic kidney disease, as I said, not all chronic kidney disease are kidney failure. Early stages, like stage 1 and 2, you can still do a lot for these kidneys. So, how do you define the stages of the chronic kidney disease? It's based on the percentage of kidney function. When it is less than 15%, that is when we call it as kidney failure. And that's the one the community is very well aware of, and where we go for dialysis and other treatment modalities. So, how do we diagnose that someone has chronic kidney disease? The second bigger problem with chronic kidney disease, apart from the epidemiology, is it is usually asymptomatic. Only in advanced stages like stage 4 and 5, you start developing symptoms. And those symptoms are also not specific for kidney. If someone is having an heart attack, they'll have chest pain. So it's very easy. But these symptoms are not very specific to the kidney most of the times. What are the symptoms? You can have fatigue, that would be a very non specific symptom. If the urine output decreases, when I say if, it's a big if, not all patients with chronic kidney disease have decreased urine output. If the urine output is decreased, then you can have swelling in the feet, swelling around the eyes, but more common is having a different pattern of urination where you start urinating more in the night than in the daytime. So the earlier symptom could be someone getting up 2 to 3 times in the night, but not all urination in the night is indicative of chronic kidney disease. Then seeing bubbles or foams in the urine could indicate kidney disease. If the stage advances more, then you will start developing more bothersome symptoms like decreased appetite, not able to eat anything, starting to feel short of breath, initially only during work, later on, even at rest. Once they progress into kidney failure, then they have trouble with sleeping, concentration, significant itching can happen, change in the taste, recurrent vomiting, then muscle cramps can also be features. From head to toe, you can have symptoms due to chronic kidney disease. But as I said, decreased urine output, which is very specific for the kidneys, is not always present. How to diagnose chronic kidney disease? The doctor will do a good history taking, physical examination, and a blood pressure measurement. Then we do urine test and then blood test called popularly KFT or RFT, that is kidney function test or renal function test. It consists of urea, creatinine, sodium, potassium, chloride, bicarbonate, calcium, phosphorus, and other salts and minerals. Then we look at the ultrasound, and the ultrasound, as I said, will show smaller kidneys. Among all the blood tests, creatinine is a very specific marker of kidney disease, and I was talking about the percentage of kidney function, which is usually an extrapolated measure from the creatinine values. Very rarely, you might need a kidney biopsy to diagnose what is ailing the kidney. So, as I said before, kidney disease is asymptomatic and it's picked up very late. And once it's picked up in the late stages, then dialysis and transplant are the options. So, what should we do? We should aim at prevention, especially primary and secondary prevention. Primary prevention means you identify people with risk for kidney disease and prevent development of kidney disease. And the secondary prevention is picking up chronic kidney disease in stage 1 or 2, and then you give medications to prevent progression. So, who are at risk for chronic kidney disease? As I mentioned earlier, diabetics and patients with hypertension. That is high blood sugars and high blood pressure. They are the biggest population to get kidney disease. Then, if you have a family member, like a diabetic with a family member also having kidney disease, then the risk is higher. Increasing age is a risk for chronic kidney disease. Obesity and smoking are also risk factors. Cardiac and kidney are very intertwined. Chronic kidney disease is a big risk factor for cardiac disease. So, a lot of patients with chronic kidney disease will develop, more number of them are likely to develop a cardiac disease rather than go on to dialysis. And patients with long standing cardiac disease can also develop kidney disease. So, how to pick up early? As I said before, urine test, blood test, they're all the same. But one of the tests which will pick up the kidney disease earliest, especially in diabetic hypertensive population, is called a urine microalbumin test. If you do the urine microalbumin test and when you pick it up in the microalbumin stage, many a times we can also reverse the disease. So, my message today is the chronic kidney disease is an irreversible disease which tends to progress, and it is better to prevent than to treat. So, how to prevent? How to take care of your kidneys? Remain fit, monitor your blood sugar and keep it under control, keep your blood pressure under control, eat healthy, drink enough water, don't smoke. And the most important message I'd like to give is don't take over the counter medicines on the regular basis or any medicines for that point without prescription or more than the prescribed period. Certain antibiotics and ulcer drugs can also cause kidney disease. And if you are one of the high risk categories, you should get your kidney function checked as prescribed by your physician. Most of the times it is done annually. Thank you.
Thank you, Dr. Abhirami, for that very beautiful explainer. We'll now move on to our next speaker. A leading name in nephrology in Trichy, Dr. T. Rajarajan is the consultant nephrologist at Kauvery Hospital's the Trichy Thanur Center. He did his DM in nephrology from Stanley Medical College, Chennai, and has a rich work experience of more than a decade. A member of the International Society of Nephrology, he has authored and published several papers in scientific journals and presented papers at conferences and been a guest faculty at medical colleges. He is credited with doing several rare surgeries, and his areas of interest include renal transplantation, electrolyte imbalance, and glomerular disease. Dr. Rajarajan's talk will focus on management of chronic kidney disease. Welcome, Dr. Rajarajan.
Thank you, one and all. And I wish everyone a World Kidney Day, which is going to be held tomorrow. So Dr. Abhirami has beautifully enumerated the awareness one to have for a kidney and about the chronic kidney disease. Now my focus of talk is regarding the management of chronic kidney disease. Once it happens, what to do? Please share the screen. Slideshow. Okay. Actually, we all know that there are stages in chronic kidney disease, as Dr. Abhirami enumerated. Why? Because certain stages will have symptoms, actually. So when the patient progresses from stage 1 to stage 2, stage 3, stage 4, stage 5, symptoms is going to occur. Like often most of the patients in stage 1 have no symptoms. That's why the screening will give you the clue that the patient is having the kidney disease. When they progress to stage 2, mostly they will have some hypertension and proteinuria, which can be detected by urine examination, clinical examination. As they progress along the stages, stage 3, they will have an anemia, bone disease, and later stages will have a fatigue, swelling, nausea, vomiting. So why you have to detect and manage CKD? Because it slows the progression of kidney disease, it prevents complications, it reduces the cardiovascular mortality, and reduces the altogether morbidity and mortality. So it reduces the risk of cardiovascular risk by 20 to 50%. So treatment in the early stages, whenever the patient comes to us with chronic kidney disease, which is again, it's an irreversible and progressive disease. Initially, it is managed with adequate blood pressure control and blood sugar control and your food, lifestyle and food modification. Food should contain good bioavailable protein intake and low potassium. We often, when the patient is having a hyperkalemia, we advise low potassium diet and low phosphate diet and salt restriction around 6 grams, depending upon the etiology and depending upon the retention, and fluid restriction if the patient is having a volume overload. Another one important thing is you have to avoid over-the-counter medication. I'm stressing upon it again because it increases the progression. It increases the progression of the kidney disease. Then you have to take care of the anemia. You have to take care of the bloods. Once the kidney disease progresses, you have anemia. So you need to have an injections like erythropoietin, iron supplementation to manage anemia of chronic disease. Again, your bone health will be in trouble whenever you have a chronic kidney disease. So appropriate medications to strengthen your bones is necessary. And you have to stop smoking, alcohol. So these are all the early management of kidney disease. They have to visit the doctor, specialist nephrologist once every time when they call up, and they have to maintain a regular follow-up and medications to retard the progression of the kidney disease. So even if you do all these maneuvers, still the kidney disease progresses. Actually, it progresses from CKD to end-stage renal disease. Many patients ask why it happens, because you have a lower number of functioning nephrons. For example, if you have a 20, 30, 50, if your creatinine is around 2.2 or 3, it means that you are having only 40% of nephrons functioning. 60% are not functioning. 40% cannot function the work of 60%, 60 people. So tend to naturally, as the time goes on, these 40 people will come down, reducing number to 30, 20, 10, and 5. That's why you see that rise in creatinine in spite of this treatment. So low risk category, they will always progress. They all progresses depending upon the risk, like proteinuria, uncontrolled hypertension, blood pressure, and sugars and all. The risk factors, risk may differ, but eventually, most of the people will end up in end-stage renal disease. So once they reach the end-stage renal disease, that means that your body needs support apart from medicines to take care of your daily activity, to reduce your uremia. So these are all the treatment options available. One is a hemodialysis, which is in-center dialysis. That is, your patient has to come to the hospital regularly to get a dialysis done. And this is another modality called as a chronic ambulatory peritoneal dialysis, where the patient do the dialysis at home. And of course, these two are the controllable therapies. They cannot cure the disease, but it will reduce the uremic symptoms to go and to manage the patient. And it has to be taken for lifelong. Another one thing is the curative for this kind of treatment disease is renal transplantation surgery. So this is only curative modality available till date to cure this disease. So when to start the patient on renal replacement therapy or dialysis means once you have these kind of symptoms, you can have renal replacement therapy, but you should not wait the symptoms to take over of you. Many people will wait till the symptoms to become prominent to start on hemodialysis, many patients. So that's not so. So we used to prepare for dialysis whenever your GFR, that is, you calculate GFR from the creatinine value, and many of your iPhone App Store or Google Play Store will have a GFR calculator. You can feed in the creatinine and parameters like age and sex, and you get the GFR immediately. So once the GFR falls, and we will monitor the GFR every month on the during visit. Once the GFR falls below 20, so we prepare the patient for dialysis and transplant. And creation of AV fistula. This AV fistula is nothing but a small surgery done in the arms to connect the vein and artery so as to get a mature vein to get the adequate flow for the dialysis to happen. So this creation of AV fistula is more important foremost in all patients who are not willing for transplant to prepare for dialysis. You should not wait till the symptoms of uremia takes over. Trivial symptoms of uremia, even smaller symptoms, trivial symptoms of uremia in a patient with GFR 15 is an indication for dialysis. Dialysis, as a common perspective, people are conceiving as a last hope treatment. It is for the preparation for an eventuality. Dialysis is to keep the patient bedridden, only to make him alive, and don't imagine about the professional. These are all the common perspectives of the patients, the common myths about the dialysis. So, but this is not so. It is a only organ system failure. Renal failure is only organ system failure where patient can lead a normal life of dialysis. One of the best medical discoveries of all time said to be a dialysis. How it happens for a common person, it works on the principle of diffusion, right? If you have two compartments, compartment A, compartment B, separated by semi-permeable membrane, the diffusion process, that is a movement of solute from higher concentration to the lower concentration, is a process called diffusion. This is what we have adapted in dialysis. And this being done by this filter. This is the artificial kidney where the diffusion process occurs between the blood and the dialysis flow. So if you see, this is a dialyzer, and you see, so this is the fiber component. This is the blood component. This is the blood compartment. This is the dialysis compartment. So the ions which are present, solutes which are present more in the blood, like urea, creatinine, middle molecules, uremic toxins, will move from blood compartment to the dialysis compartment. And the essential bicarbonate which is present in the dialysis will be moving from this compartment to that compartment. So this is the mechanism of dialysis, what we are doing. So ESRD, as we think, it is not a very bad disease to have. Many people will think this is a very bad disease. If you see this graph, it is better than the myocardial infarction, heart failure, stroke. So it's not a very bad disease. With the available treatment modalities, still the patient can lead a good normal life. These are the celebrities who are having the renal failure and dialysis, and still they were doing their professional work successfully. And these are the longest surviving dialysis patient. She was surviving for 44 years of dialysis with single AV fistulas. And this is our center's patients who are surviving for 12 years on hemodialysis and doing their professional work. And another modality of treatment which we discussed before is a chronic ambulatory peritoneal dialysis. It is done in home. It's like a bag which should be the PD fluid will be instilled into the peritoneal cavity, and the blood capillaries in the peritoneum acts as the diffusion process. Actually, you have to connect the bag, and with the catheter, you have to connect the bag. It will get filled in, and it has to be drained and again filled in. It is like a process done 3 or 4 times a day at home. This is how it happens. This is a bed vessels in the peritoneum, and again, like your diffusion process, the exchange occurs between the peritoneal cavity and the peritoneal membrane. So these are all the types. This is like manually done peritoneal dialysis, and we have a machine called as APD machines, where automatically this machine will do a peritoneal dialysis cycle when the patient lies down during night. These are all the frequency of the cycles. Patient will have a machine connected to them at the night and get sleep, and the exchange is taken automatically till morning, and they can leave home and do their work in the morning time. So these are all the various modalities we can do the peritoneal dialysis. And this how it looks. They can wear a dress, they can go wherever they want, and they can attend whatever work they want to do, still having the dialysis done. These are all the some of the patients, smaller, younger patients. These are all the some of the patients we are on hemodialysis, peritoneal dialysis, doing their work successfully. So what are the trends of renal replacement therapy in India? There are 2.5 lakhs of people are added to ESRD pool every year in India, and prevalence of ESRD in India is 232 per million populations. Such a whopping number of ESRD patients are there. There are around 1.3 lakhs of patients are getting hemodialysis, and 8,500 to 9,000 patients are on CAPD in India. Compared to this number is less. 60 to 70% of patients stop renal replacement therapy due to economic reasons. But government is chipping in with very much good actions. Our Tamil Nadu government, Chief Minister Comprehensive Scheme and the PMJ, Prime Minister scheme, offers a free maintenance dialysis to the patients to both government and private hospitals. And Maklai Thedi Maruthuvam from Tamil Nadu government offers a free door-to-door supply of PD fluid for the patients free of cost. These are all to increase the penetration of dialysis to these poor ESRD patients. So as they should not stop the dialysis for economic reasons. So with this, I stop. Thank you for the opportunity.
Thank you, Dr. Rajan, for that very nice presentation and also sharing those little positive stories of celebrities who are living long, people who are living long enough. So we now move on to our final speaker of the day, Dr. Prabhu Kanchi, consultant nephrologist in Chennai. A graduate of Madurai Medical College, he did his MD in internal medicine from GSVM Medical College, Kanpur, and obtained his DM in nephrology from PGIMER and Dr. RML Hospital, Indraprastha University. He is also a fellow of the Ottawa Hospital, Canada. His areas of specialization are renal transplantation, peritoneal dialysis, interventions, and intensive care nephrology. He will now speak on kidney transplants. So over to you, Dr. Prabhu.
Thank you so much. First of all, thank you, Hindu, for the wonderful opportunity to meet our the general public. And this is an awareness campaign we are conducting on the eve of World Kidney Day, which is being celebrated tomorrow. And my previous speakers have spoken about everything about how to monitor, how to diagnose, and how to prevent and progression of kidney disease. So as everybody pointed out, it's kidney disease are very silent disease. They don't cause much symptoms, and then if we miss the symptoms cues earlier, we might land up in advanced kidney disease. And Dr. Rajarajan sir spoke about the dialysis, which is one of the options for advanced kidney disease. I'll be talking about the transplants. So mainly these are common queries we face regularly when we see an advanced kidney disease patients. So regarding the transplant, the first important question will be, when do I need a transplant? And do I need to do it early or can I wait? And then the patients will be really asking, do I really need a transplant? Can I remain in dialysis? And the questions about the safety of transplants and the failure rates and how long the new kidney will survive and how the life will be after transplants. Will there be a lot of infections? Should I be in isolation for at home for 6 months or 1 year? And how safe will be my donor will be? And the other questions will be when the patients and donors might have different blood groups. So if the transplant is possible. And sometimes, many times the patient won't have a donor from the family. So their query will be, how do I get a transplant kidney done? And if I'm registered, how long should I wait? So my presentation will be answering most of the questions. So as Dr. Abhirami Madam pointed out, there are 5 stages of kidney illness: stage 1, stage 2, 3, and 4 and 5. So mostly the patients are asymptomatic up to stage 4 and 5. And stage 5 means when the kidney function is less than 15%, we call it a stage 5. And most of the patients develop symptoms, significant symptoms, only when the kidney functions, the GFR falls below 10%. And that's when we give them an option of either going for dialysis or for a transplantation. So the patient may choose either way, whether they start with dialysis and then later on plan for transplantation, or they remain in dialysis. Or sometimes when the patients can straight away opt for transplantation if they're not willing for dialysis, which we call preemptive transplants. And the study says when patients go for transplantation without even starting dialysis, their outcomes, long-term outcomes are better. So that's called a preemptive transplant, which we are offering most of the patients now. And the main query will be, patients will have a lot of fear about transplant. So they ask whether I can remain in dialysis. I'm doing fine in dialysis. Do I really need a transplant? Can I be healthy in dialysis? Yeah, I mean, patient can opt for either transplant or dialysis, but as per study, the transplant gives the most optimal, that's the most optimal treatment and standard of care nowadays. And because it improves the quality of life, it improves the longevity of the patient. The patient live longer, they live healthier, and their overall quality of life is better. The diet is better, and overall health is better. So we obviously suggest the patient to go for a transplantation. And as there are patients, definitely patients who live longer in dialysis. The recent advance in dialysis, it definitely improves the quality of life. The new online HDF, they do have a great impact in the survival of the patient. But still, there are many patients who suffer in dialysis, and then the Japan has, I think, most the good data about dialysis. Their 5-year survival rate in Japan is 60% compared to 50% in US. Basically, it means that uh, only 50% of patients will survive in dialysis after 5 years. So basically, the reason why dialysis is cannot, like, the patient cannot live like more than 12 years, 15 years in dialysis. That dialysis, even if you do twice a week, thrice a week dialysis, it removes up to 20% of waste products and toxins from the body. And in a longer run, it can cause heart diseases. Obviously, patient with an end stage on dialysis, they have a lower immunity compared to rest of the patients. They have anemia, they have weak bones, and then fatigue. And again, from my point of view, spending 2 to 3 days in a hospital hooked to the machine, I mean, that might not be a good option for the patients who are already working. And the patient do have a severe diet restriction. Salt, they take the salt very minimally, and water intake. Many of the patients will have water restriction too. So this all can compromise the quality of life. And obviously, many of them, they do have poor quality of life. But some patients really do well in dialysis. And then, as Dr. Rajarajan told, that they'll live up to 10 years, 12 years in dialysis. Those are very lucky patients. And so that's the reason we always offer transplant as the first option for any advanced kidney disease patient. Only we don't go for transplantation when the patient have either one of these three disease, whether if they have severe active infections, we do not suggest. If patient have active cancers, we do not suggest. And the patient's heart function is very, very poor, we do not suggest transplantation. Rest of the things, any patient can undergo transplantation. So his transplant is very safe procedures. Obviously, it's only a 3.5 or 4 hour procedures, and the entire process can be completed in 4 hours. Either you can go for a open surgery, which everybody is doing, and robotic surgery. Obviously, in the recent last 2 years, we have been offering robotic surgeries for kidney transplant recipients, and especially for those patients who are obese, and they end up getting small scars, and surgery is like is comparable to any open surgery. And the when the patient undergoes transplants, their recovery is very quick, and then start eating, and they start walking in next couple of days, and then they go home in 5 days. Unlike the transplants which used to happen 10 years before, where the patient stays for 14 days, 10 days in hospital, patient goes home in 5 days nowadays. And with the proper evaluation, this is one of the safest transplants compared to the other transplants like liver, heart, and lung. Kidney transplant is one of the simplest and safest surgeries someone can undergo. And with the current evaluation system we do prior to transplantation, the immediate failure rates are unknown. It's very, very rare. Nowadays, with all the advancement, we cannot expect an immediate transplant failure. So how long the transplant kidneys will work? Again, this is an American data, not an Indian data. It has improved a lot. With the living kidney transplants, 20 years before, first year survival was 94%, which is improved to 98% now. And then I want to mention again, this is an US data, not an Indian data. So patients, transplant recipients used to live up to 8 to 10 years before. Now with the brain dead transplant, they can live up to, the kidneys last up to 12 years. And living transplant, and they have the US, they have brought the outcomes to 20 years, close to 20 years now. But these are all yeah, Western data. Indian data, we still lagging behind, absolutely, but there's still room for improvement. And down the line, we'll be achieving these great goals. And how will be the life after transplantation? The myth is that patient thinks that once we get a transplantation, they should be quarantined, they should be in isolation for 6 months, 3 months inside home. They can't meet anyone. That's the mostly prevalent myth. That's because of the fear they get because of infection. So, but the aim of the transplant is to give back a normal life, and we don't quarantine a patient for 6 months. The patients are back to normal diet within few days with very minimal restrictions. Only we suggest to avoid crowds, and we don't suggest any isolation at home. They can be free at home, and even they need not wear any mask at home. Only when they go out, they need to wear mask, and then prevent exposing themselves from any obvious sick patient. And usually the patient goes out and then goes for a walk routine. They do their routine work in 2 to 3 weeks time, and in fact by end of 3 months they can resume their jobs, and then patients do start exercising. So that's advancement in the recent years. And coming to the kidney donation, so the main question will be like, is my donor somebody's father, mother, or wife, or husband they're donating? The question will be whether my donor will be safe after donation. So I would say not everybody is a donor, but evaluation is the key. If you do a proper evaluation, we can identify who will be a safe donor and who will not be. And we have our own extensive, very elaborative test sets, and then we ensure both the short and long-term safety of the donors. And we do reject of our 5 to 6% of donors if we think if he donates, the patient might land up in problem long term. So if we see a small risk in 10 years time after donation, we do reject. So we don't accept all patients. After only thorough evaluation, if we are very sure about the safety of the donor, we go ahead. And obviously all our surgeries are laparoscopy. That's become a standard of care now. And it's only a 2 or 3 days stay in the hospital. The patient goes home walking, and then there is no long-term medication. They are back to their normal life in 10 days or 2 weeks time. And I want to mention that out of 1,000 donors, this is international data, only 2 or 3 out of 1,000 donors might develop hypertension and some form of CKD years down the line. But when the donor is in regular follow-up, and if they have a healthier lifestyle after donation, we can even reduce the risk of developing any complication down the line. So if many times we face the blood groups are different between the patient and the donor. So will that be successful? That's successful. The ABO incompatible, the blood group mismatch transplants. We are practicing in India for the past 12 to 14 years, but still patients do have some doubts about it. And I'm pretty sure that the outcomes of different blood group transplants are as good as same blood group transplantation. Only that they need to remove that blood group antibodies, that extra procedure is needed to make sure the transplant goes well. So if somebody is A group and he naturally carries an antibodies against B group, and similarly if somebody is B group, he has antibodies against A group. So when there is a different blood group transplant we are planning, we need to remove these harmful antibodies. And once they are removed, once they are a safer level, we can go ahead. And by end of two months, these antibodies doesn't matter, and the patient used to have the long-term outcomes of different blood group transplants are as good as the same blood group transplant. And so what if there is no donor in the family? Unfortunately, half of our patients do not have a donor, or they don't have a healthy donor in the family. For those patients, we advise them to register their names for brain donation. And in Tamil Nadu, that's an organization called TransTan. That's a government body which regulates the organ donations. It's the authority of transplant in Tamil Nadu. And this is a website you can log in, and then anybody can read the information. You can go to both government hospital and private hospital with the transplant licenses. All this information is available in the website. And in those hospitals, the transplant coordinators will help you enroll after basic test. And usually the waiting time all over the world, waiting time is 3 to 5 years. That depends on blood group. O and B, you can get an early kidney. If for AB, then the waiting time could be a little more, and also depends on hospitals where you are registered. But as I said, the average waiting time is 3 to 5 years, but it could be less if we opt for something called extended criteria donor. So the waiting time can be significantly reduced. And yeah, thank you so much for the time.
Thank you, Dr. Prabhu, for your valuable inputs. And I would like our audience to put in their questions in the chat box. Dr. Abhirami, maybe I could start with you, because we are on this talking on the World Kidney Day and trying to spread awareness. CKD is, as we all said and understood, is a zero symptom disease. And we also know that the message to have annual medical checkups is sent out to people. But still, as you also pointed out briefly, that until we get a chest pain, we don't go to a doctor. Until we get a headache, we don't go to a doctor. So just to re-emphasize, reiterate, what would be the best and the earliest way to find out? I mean, suppose a person is absolutely normal and young and doesn't feel anything, but still you would recommend that a person should go for the blood test or the urine test? I mean, when should we start? And also, if you could also include about children, a little younger age group, whether they are also affected.
Yeah. Okay. The screening is meant only for patients with high risk. As I
Mm.
said, people with diabetes and hypertension. But the bigger problem is even the ones with diabetes and hypertension do not know that they have diabetes and hypertension. So
Mm.
normally the recommendation now is you start at the age of 35 and you start looking for the high blood sugar and high BP for everyone. Anyone over 35 should be getting themselves checked for diabetes and hypertension. If you do that, then you can start screening once a year when you have diabetes or hypertension. Regarding children, children do develop kidney disease. It's not like they don't, but the problems are different in children. Obesity is now an issue, but most of the times the kidney disease in children are due to either abnormal development of the kidney and the tract or certain genetic disorders which present early. In children, the structural abnormalities are easy to pick up. They have pain, change in the way they pee, and then change in the color of the urine, passing blood. That's easy to pick up. And then we also always routinely get scans when the mother is pregnant. So some of these abnormalities are picked up even during that time. What is difficult is certain genetic disorders, certain tubulointerstitial diseases, where again there are no symptoms in children. What is something you can watch out for in children is a failure to thrive. That is, the baby doesn't gain weight, the baby is not growing in height or weight, and it's incessantly crying, not doing its usual motor activities. It could be a lot of diseases, it could also be kidney disease. So that's something you need to watch out in children. And children who continue to bedwet beyond an age, that's another population which should get evaluated. Children with urine infections should get an evaluation done. Okay, in adults, anyone over 35 should get their blood pressure and sugar checked. Along with that, they should get their kidneys checked, and then once a year, depending on the risk. As I mentioned in my talk, urine microalbumin is one of the tests to pick up kidney disease at the earliest. Otherwise, it is routine test like what we do for diagnosing. So it's KFT, urine examination, blood pressure, and ultrasound for the kidneys.
Do you find your patients in denial when they come to you? Like, as you said, no, you give 3 months' time. If the disease persists, then you consider it CKD. Then again, the CKD to the end stage renal disease, that transition. So, how much time does that also take? Does it vary from patient to patient? And do you find them in denial? And do they, if they feel good and they drop out of the treatment protocol?
Yeah, I have three sets of patients. One set is the one who would listen to you and do what you're saying. So we'll not talk about them. The other two set is two extremes. One set is they believe they are totally asymptomatic and they call this a salt. So they'll say in Tamil uppu. So I have slight salt, nothing to worry, I'm absolutely fine, nothing needs to be done, and they leave it, and then when the symptom starts they come back after 2 3 years, and at that point the only option they have is dialysis or transplant. The other extreme is people who get very anxious because we tell them this kidney disease is not reversible, then nothing enters into their head after that. We also tell them, though it is not reversible, a lot of these patients do not go on to dialysis at all. That the kidney disease can be maintained with medications, diet, lifestyle, etc. But that just doesn't get into their heads, and then they go looking for solutions and false promises, wherein they are told they can reverse any kidney disease, and a lot of these people end up getting treatment from what they read in the WhatsApp, or certain herbs, plants, and the entire gamut, and they actually land up with more trouble. So what we need to understand is chronic kidney disease is definitely not reversible, but not all of them go into kidney failure. Even the ones who go into kidney failure, we have treatment options to delay the progression to kidney failure. All that they need is to meet a nephrologist, have a good treatment plan, and stick to the plan and continue monitoring. So neither should they deny or neglect their disease, nor should they hyperreact and go for all kinds of remedies to correct it.
Dr. Rajit, you mentioned the two types of dialysis. So I just wanted to know, like, what is the basic difference in the two, and why is that a choice the patient gets, and or is it the cost factor, convenience? What is the basic difference between the two types?
Good question to answer. So these two modalities of dialysis, as far as efficacy wise, studies show they are both equal. Actually, there is no difference in efficacy between the two modalities of therapies. So why we opt for hemodialysis and CAPD? One is patient's choice is number one. If they want to have a peritoneal dialysis, they can go for it. Otherwise, they can go for a hemodialysis. That is one is patient choice. There are certain indications. There are certain indications. There are certain sections of patient which favors hemodialysis. There are certain sects of patient which favors peritoneal dialysis. Like patient who have a severe cardiac failure, patient having a stroke with a risk of intracranial hypertension, patient who is a pediatric age group, and a patient who have a poor blood vessels where they we cannot do a fistulas and get a hemodialysis done successfully. These patients benefited by peritoneal dialysis. On the other hand, if the patient is having a large hernia, patient is having a previous abdominal surgeries with a lot of adhesions inside the abdomen, and these patients cannot be done with peritoneal dialysis, and this patient has to be stick on with peritoneal hemodialysis. As far as the cost is concerned, hemodialysis, depending upon the center to center, there are differences in amount of cost amount, ranging from 1,500 to 2,500 to 3,000, depending upon the hospitals. Average, it costs around 1,500 to 2,000 rupees per session. So they have to go for a 12 session per month actually, and peripheries they are doing 2 sessions per week. That means 8 sessions per month. You can calculate the amount involved. For peritoneal dialysis involved, for the peritoneal dialysis they have to do a 3 to 4 exchanges per day. So the total amount of cost for peritoneal dialysis will be around 28 to 30,000 per month actually. Cost wise, yes, peritoneal dialysis is expensive. And the one positive point is logistic issues will be settled. Actually, patient from a different center, periphery, who has to travel along for a hemodialysis, and the patient who don't have a patient that's bedded, actually, they cannot be moved up here and there. So these are all the sector patients who can benefit from peritoneal dialysis as far as economy is concerned. And here they have to come to the hospital every second day with attender, and they have to stay literally. It is hospital becomes a second home for them actually for a hemodialysis patient. But peritoneal dialysis patient, they can stay in home, they can do the dialysis, they can visit the doctor every month to get his monitoring done. So these are all the basic difference between the two.
Dr. Prabhu, you being the transplantation surgeon, you also mentioned in your talk about a waiting period of 3 to 5 years to get the organ. So, how do we address this demand supply gap? I mean, if you could just throw a little light on the live versus the cadaver donations.
Yeah, yeah. So if for the cadaver transplant, so as I said, the waiting time is going to be 3 to 5 years, which is quite long, and then the patient do suffer in dialysis. The only way to reduce the waiting time, as I said, this is the scenario all over the world. But to reduce the waiting time, the only way to reduce the waiting time is to generate more organs and then promote an organ donation, which the government is already doing. I think we are seeing a rise in the organ donation in the recent past, and then recently the government announced the honorary this thing for the donors. So The last in January, we saw a very, very big spike in the organ donation. Nearly 30 donations happened in January this year. And if this trend continues, I think the number of patients waiting for organs for every organ will come down. And the best way to reduce this waiting time is to promote organ donation and bring awareness to the public, and then educate the patients and general public about the donations. More the organ donations, more the transplants, and less the waiting time will be. And we are far behind the rest of the Western countries and European countries. I think the donation rates in India were like zero point 0.3 per million, which is now improved to I think 0.7. Hardly 1 in 1 million the patient they donate. Compared to an European countries, that are close to 30 people donate for 30 in 1 million they donate. India is only 1 in 1 million. So if the number of donation increase, definitely this waiting time will come down drastically. And as we discussed earlier, the number of road traffic accidents, number of patients expiring in the hospitals, number of brain dead patients in India are huge. The number of ICU beds, number of deaths are like compared to any other country, it's very, very high. And if you could promote organ donation in a bigger way, I think the not just the kidney patient, but every liver patient, heart patients, they'll be benefited.
Right. So now I'll start taking the questions quickly. Madhusudan is saying that pain in right side hip or lower back pain is it related to any kidney issue or CKD? If somebody is having pain on the right side hip or a lower back pain. Who would like to take that? Dr. Abhirami would like to answer.
Yes. So the pain in the back, as I said, the kidney is located in the back, and then the urine tube comes from there to the lower abdomen to the bladder. So if there are stones or if there is an infection in the kidney, you could get pain in that area. But the pain also could be due to problems in the spine, muscles, and other things. But yes, pain in that kind of location could be related to kidney. A simple ultrasound will help us in identifying.
There are a couple of questions on diet. I think we have not touched upon the diet. Like, so now, whether a CKD patient can take protein products, dal and paneer on a daily basis. Priya Balaji wants to know. Yeah, Dr. Rajan, you were saying something.
Yeah. So diet is important in CKD management actually. So protein intake, as the viewer asked, protein we usually a normal person will take around 1 gram per kg body weight of protein per day. For a CKD patient, we advise around 0.65 to zero point 0.8 grams per kg per day. So a little lower than the normal intake of protein. And that kind of protein should be a high bioavailable protein. What is good bioavailable protein is that protein should go for 100%, has to go for a bodybuilding. It should not be excreted waste. So because protein itself is a nephrotoxin actually. It increases the filtration, it increases the sclerosis, hyperfiltration of the glomeruli and causes sclerosis and glomerulosclerosis and interstitial fibrosis and progression. So the reference protein is called as an egg protein that contains 100% bioavailable. So you can take egg very well. And coming next in order is fish in a non-vegetarian diet. It contains around 70 to 80% of bioavailable protein. And chicken, and it comes again next in down the order. And mutton and everything and prawns, everything come lower down. So you tend to avoid this kind of protein and to stick on with egg and fish first. And chicken they can take rarely. And in case of vegetable, milk is very good protein, and soya beans is very good bioavailable vegetarian protein. Nuts and dals they can also take. These are all the compared to your meat, that compared to your mutton, chicken, and your prawns. These pulses have a good bioavailable proteins, so they can add to the diet of this, because most of the patients are protein losing and most of the patients are hyperproteinemic, so they have to maintain the diet of good quality protein to take a good life.
Gerald Jude Bosco is asking, is it challenging for nephrologists to maintain a CKD patient off dialysis and on conservative therapy?
So it's basically what kind of kidney disease the patient has. And then the patient is having an acute kidney injury. that is transient renal failure. These patients may still require dialysis, and still they can recover without dialysis. But chronic kidney disease patients, some chronic kidney disease will have some acute component. Most of the chronic kidney disease patient will have some acute insult to the kidney, causing the transient worsening of renal functions. Such kind of patients might require transient dialysis depending upon indications. Later, once the kidney improves back to the baseline level, chronic kidney disease level, they can be taken off dialysis. But once a progressive disease, once we label as the end stage renal disease, like when the progresses across the stages and reaches end stage disease, then there is no point of reversibility. They have to be on dialysis lifelong, because dialysis cannot cure the disease. It takes care of what the kidney does to the body. So as long as new kidney comes in a like transplant, they have to continue on dialysis.
Dr. Prabhu, are immunosuppressants required for transplant? And also, if somebody has had a kidney transplant and survived for 15, 20 years, is the second kidney transplant also can be done or recommended?
Yeah, the immunosuppressive medications are part of the life. So we start from day one of transplantation, and the patient need to continue it lifelong. Even though the risk of rejection comes down significantly after 6 months, but there is still a small risk of rejection, because we are getting kidney from even from mother or father. You are only 50% matched, and then there's a small risk of rejections even after 6 months. So we always suggest the patients to stick to their the immunosuppressive medication. Plus, always suggest them to take it on time. Even after many years, multiple years down the line, the patient can reject. They go for significant rejection if they stop the medication. So it's a lifelong medication, no doubt about that. And regarding the second question, after retransplantation, yeah, retransplants are possible. And only thing is like the risk of rejection and infections, all those complications for the second transplant, they need to be evaluated properly, because all these risks are a little bit more compared to the first transplant. First transplants are considered a little easier, because the patient immune system is naive and then not exposed to a lot of antibodies. But once you put in an organ, the body reacts to that and develop a lot of antibodies. And doing a second kidney little challenging, both surgically and medically. But second retransplants are possible. In fact, I want to mention we recently did a third transplant for the patient. The patient had a first transplant when he was very young, at the age of 10 or 12. It lasted for 10 years, and then had a second transplant from somewhere else, which he lost after 15 years, I think 15, 16 years. And then we did a third transplant for the patient. So retransplants are definitely possible. Only thing to keep in mind is that the risk of rejection, the infections are a little bit more, but that can be mitigated with proper evaluation.
So the website that you mentioned for registering,
Yeah.
Priya Balaji wants to know that can an NRI who has been diagnosed of CKD in India also register on that website?
Yeah, true. Anybody can register. In fact, Tamil Nadu, you can any non-Tamils, anybody in India can register. Outside foreigners also can register. But only thing is that the kidneys will be offered, not just kidneys, any organs will be offered first to Indian patients. The first priority is Indian patient. And if there is no hospital or a team or a patient is willing to take up the organ, and then only there will be the NRIs and outside foreigners, they will be offered the organs. But definitely they can register. They need to contact the hospital transplant coordinator for that. So that's definitely possible though.
Ganesh Gopalakrishnan wants to know, maybe Dr. Abhiram, you could take this, that one of the symptoms of CKD is high value of microalbuminuria. So once this value has been high and then restored back to the threshold values, what are the steps to be taken to maintain the same for a longer period?
Yeah. So it is reverted to normal because some medications were given. That medications have to be continued. You cannot say, okay, now I'm all right, so I'll stop the medications. That has to be continued. And the next thing is, of course, reducing the risk factors. So it would have been reduced mainly because of change in lifestyle, diet, blood pressure control, sugar control, and certain specific medicines which reduce the protein, microalbuminuria. So all these needs to be continued. Whatever helped you in reverting to normal needs to be continued. And frequent monitoring sequentially after that.
Renu wants you to talk about the bodybuilding supplements and their role in kidney injury.
Yes, I'm not sure if we know what and all is there in any bodybuilding supplement. Anything which is not a drug is not very well controlled in India. Anyone can come up with supplements. So I personally think anything which is not known is a toxin. Okay, so we don't know, it might be. But specifically, Dr. Rajarajan was just mentioning protein is toxic to kidneys. So too much of protein is not good. So if you take too much of protein, the protein gets metabolized and has to be excreted through the kidney, putting in a lot of load to the kidneys. The second thing would be there could be anabolic steroids in the supplements for bodybuilding. Steroids can increase your sugar, increase obesity. So these two are known factors in the supplement. But then there are a lot of these herbal kind of things, ginseng, whatnot. Among these, at least for ginseng, we know the blood pressure can go up. So I strongly recommend not to do anything unnatural, and bodybuilding can be done with natural foods and with good exercise, and a good trainer will be able to do that. That should be the way to go.
Priya Balaji says her child, of course, she's not mentioned the age, has a creatinine value of less than the normal value. Does it mean he has kidney issue?
No, there's nothing called low creatinine. So depending on the age and the weight, the creatinine can be lower, but the lab must be giving a standard reference range, which is mainly meant for adults. There is no disease called low creatinine unless someone is very emaciated, has no muscle mass at all. Otherwise, I would not worry about a lower creatinine.
Mhm. Actually, there are a lot of questions on food, repeated questions, and somebody's asking for a separate webinar on exclusively on diet for CKD patients.
Should do it.
They really want a list of what we should eat and what we should not eat. Dr. Prabhu, should a patient have already started on dialysis to be listed in that transplant for cadaver donor?
Yeah, so the transplant rules are like once the patient is in dialysis at least for 3 months, and then only they will take it up for registration. Since the number of patients in the list is very huge, they don't accept patients who are on dialysis less than 3 months. So basically, the patient should be on the regular dialysis for 3 months, and then only somebody can go for a registration under transplant. The rule is only limited to in the transplant only. Outside India, there's no such a rule. Anybody with the CKD stage 5 can go ahead. But since the number of patients are too high and too many patients on wait list, the 3 months is the minimum waiting time on dialysis to get registered in transplant.
Is there any link between appendix and kidney pain or disease? Nothing. Okay. Hmm. Okay, this child, of course, is 5-year-old. That lady is writing now. Anyway, Roshni says my creatinine is persistently 1.8, and I have been diagnosed with CKD, hypertensive nephrocalcinosis. I am 26 years old. I want to know how serious is my condition and would I require dialysis in future? Dr. Rajan.
So she is hypertensive nephrosclerosis probably.
Yes.
And she is coming in the category of chronic kidney disease, no doubt about that. So this thing, to retard the progression, what we have spoken before, right? Good blood pressure control is very important.
So your voice is a little bit echoing. Yeah.
Am I audible?
Yes.
So your blood pressure should be under control and it should be less than 130/80 always. And I usually advise the patients to have the blood pressure monitor at home and to check the BP regularly and to maintain a chart of blood pressure. This is the foremost cause of progression. Another one important thing is the salt intake that we have discussed, reduction in salt intake to control of the blood pressure and also your kidney damage, and also protein intake, what we have told. And she has to address the issues of phosphatemia, hyperphosphatemia, might be having a higher phosphate level. So she has to restrict phosphate containing foodstuffs and a proper management of anemia. If she has an anemia, hemoglobin is low, she has to do that. And foremost thing is she has to avoid nephrotoxic agents and some talk was going on regarding the bodybuilding thing and all. And as Madam rightly told, that anything unnatural should not be taken, because bodybuilding supplements contain lot of proteins and all that is harmful to the body. And avoidance of nephrotoxic agents, the unknown medication, whatever may be it, unknown medications they should not take, and regular exercises, maintaining of the correct body weight, and should not become obese. Like she should maintain an adequate body weight and daily exercises that will get you, and proper regular consult with the nephrologist, and the drug what they prescribe has to be taken care of. So diet compliance, drug compliance, and doctor's visit compliance will take care to reduce the progression to the end-stage renal disease.
Yeah, so I think on that note, I will have to draw the curtains because we have really overshot our time. We should all remember the valuable inputs which have been shared by our three panelists today, along with the important message of equitable kidney health for all on this occasion of World Kidney Day. I thank all the doctors for sparing their time on a busy working morning to make people aware of the silent disease and clear a lot of myths and doubts, particularly the fact that CKD with medical management can delay dialysis. I also thank all our participants who joined the session and sent in their questions to make the session more lively. The webinar was presented jointly by the Kauvery Hospital and the Hindu Wellness Series. Thank you very much.
Thank you.
Thank you. Thank you. Thank you.
Thank you.